Yeah, thank you for the invitation to this fantastic event, Sport and Knowledge Together. I love that. I'm going to talk about high-intensity interval training in de novo heart transplant recipients in Scandinavia. This is a study we are doing now, so there are no results, but I'm going to tell about the study. The main focus for this presentation will be background, why we are doing this study. Mostly of the presentation will be about the HIT study. I will talk a little bit about exercise with a newly transplanted heart and future plans with our research. So first, the background. We know that heart transplanted patients, they have a reduced VO2 peak. And we know that the oxygen uptake is an important outcome after the heart transplantation. There are few randomized controlled studies on the effect of exercise. We have seen it in this forum in these 3 days. But we know that high-intensity interval training is proved to be an effective tool to increase the functional capacity in healthy subjects as well as in patients with cardiovascular diseases. Recent studies also show that high-intensity interval training is feasible, safe, and efficient also in maintenance heart transplant patients. We have studies from Norway and from Denmark. Before I go further, I have to say something about what is high-intensity interval training and what is moderate intensity training. High-intensity interval training is, of course, exercise with high intensity. It is short bouts with really high intensity. In Norway, we use this typical 4 times 4 minutes model. It's 4 minutes bouts with high intensity and 3 minutes with an active pause between the interval bouts. Healthy individuals should lay at 85 to 95% of their maximal heart rate. So that's really tough training. But the heart transplanted patients, their heart are degenerated. So we say that they should lay at the Borg scale 17, really exhausted. Moderate training, we also call it MICT, moderate intensity continuous training. That is after the steady state principle, longer periods without rest and with a lower intensity. We say that healthy individuals should lay about 65 to 80% of their maximal heart rate, and heart transplanted patients should lay at Borg scale about 15. We have some experiences from Norway. My supervisor and colleague, Katrine Rolid, she did her PhD thesis at maintenance heart transplant patients. And the title of her PhD thesis was Chronotropic Responses and Effect of High-Intensity Interval-Based Aerobic Exercise in Heart Transplant Recipients. I have given you the articles or the committee, so you can read the articles from that. The main conclusions from her research was HIIT is a safe and effective form of exercise for maintenance heart transplant patients. They were included 1 to 8 years after the heart transplantation. And the HIIT group actually increased their oxygen uptake with 17%. And they also increased their muscular exercise capacity with 17%. They had a better chronotropic response index and, very interesting, a trend towards reduced progression of CAV, which is a special form of graft arteriosclerosis, cardiac allograft vasculopathy. And after we had done this research in Norway, what about de novo heart transplanted patients? Would HIIT also be a favorable, tolerable form for exercise for this group also? We don't know. Nobody have investigated this. Actually, it's no published studies. So then, after the ethical committee in Norway had accepted our research protocol, we started in February 2013 with the following study, the HIIT study. High-intensity interval training in de novo heart transplant recipients in Scandinavia. This is a new study, but with the same intervention as in the TEX study, but it is on newly transplanted patients. So as we know, this is the first study on the novo heart transplantation patients in the world. We haven't seen any published paper about it. Our research questions are, could a HIIT protocol also be applied among de novo heart transplant patients? Is it an effective tool to improve exercise capacity also in de novo heart transplant patients? Maybe other effects, for example, progression of CAV? Is it safe, feasible, and cost-effective to run this rehabilitation program decentralized? Because we are doing that. It's not in hospital, it's decentralized. So this is a multi-center study. The responsible for the study, the main study center is Oslo University Hospital, where I'm working. And we have Sahlgrenska University Hospital in Sweden with us, and Rikshospitalet in Copenhagen with us also. Some facts about the study. The inclusion started in January 2013, and we are still inclusion patients, so it takes time. The patients are asked about 6 to 8 weeks after the heart transplantation, and the intervention begins about 3 months after the heart transplantation. That's quite early. The baseline testing are 8 to 12 weeks after the operation, and we do 1 year follow-up testing after 9 months of exercise intervention. So I think this is quite a long follow-up period. We are now also doing a 3-year follow-up in the same study population, but there are no specific intervention between the first and the third years post-operative. The HIIT study week are really busy for the patients. At day 1, they are taking their biopsy, they take blood samples, and they get a 20-hour blood pressure. And we give them questionnaire about quality of life and anxiety and depression. Day 2, they are doing an extended angiography with intravascular ultrasound and optical coherence tomography. And they are doing their echocardiography. Day 3 are the functional testing day, I will call it. We are doing a peak oxygen uptake. We are testing the muscle strength. We are measuring the body composition, and we are also measuring the endothelial function with endopath and flow-mediated dilatation. So this is a treadmill test. We have a walking protocol in this patient group. We are starting with a 10 minutes warm-up period. That's really important. And it's a constant speed interval determined from 3 to 6 kilometers per hour. The inclination increased by 2% every second minute until exhausting. And they are sitting in a 4-minute recovery sitting position, where we are measuring the heart response. And this is how we are measuring the muscle strength with Cybex 6000, which is isokinetic. We are measuring maximal muscle strength and endurance muscle strength. So what is so characteristics with de novo heart transplant patients? Most of the patients are really deconditioned. They have high doses of immunosuppressive drugs with side effects, and they are exposed for infections. The heart are really degenerated. It's ups and downs in the post-operative phase, and they are uncertain about how they will tolerate the exercise. So there are physical and mental challenges to train this group with this high-intensity interval training. I will say some keynotes about the denervated heart. They have chronotropic incompetence, all of them. They have a high resting heart rate. They have low peak heart rate, a 10-minute heart rate increase, and heart rate recovery. The consequences for the high-intensity interval training. The heart rate increases slowly in the interval bouts, and the heart rate continues to increase in the active resting periods. So we actually must guide them with both the heart rate and the Borg scale. But we also know that the heart rate response alters throughout the first year after the heart transplantation. So the peak heart rate is usually low in the beginning of the intervention period, and then it gradually increases. But the heart rate response alterations are very individual. So it may therefore be a challenge to guide the high intensity interval sessions for the physical therapists. So how practical are we doing this study? It's a decentralized training, as I said. It's all over Norway. It's with local physical therapists who many of them have never seen a heart transplanted patient before. And it's a long follow-up period. They have to train 9 months. This is how the exercise program for the high intensity interval group looks like. We have 3 periods lasting 3 months each. The first period, all the sessions are individual guided with a local physical therapist. 3 times per week. The first period we have 1 high intensity interval training session, and we have 1 resistance training and 1 combination with resistance and interval training. In the second period, also individual guided, we say 2 to 3 times per week. They should have 2 times with high intensity interval training and 1 with resistance training. And in the last period, they have 3 sessions with high intensity interval training per week. And that's really tough. This is the 4 times 4 model. We are using this. First 10 minutes warm-up and this interval bout. 4 minutes, 85 to 95% of the maximal heart rate, and the Borg scale 16 to 18. An active pause with Borg 11 to 13. They do this 4 times 4 and a cool down period 5 minutes. It's really important with a cool down period with this inverted heart. And the control group, they do the moderate intensity continuous training. They do the usual physiotherapy as per protocol Rikshospitalet. This is how we now are training the patients. They are training after the steady state principle, not interval based. Borg scale max 15 to 16. They are exercising 2 to 3 times per week, also individual guided with a local physical therapist. Also the same follow-up as the HIT group. This is how the model of the continuous training. Warm-up 10 minutes and this continuous moderate lasting 25 minutes and a cool-down period 5 minutes. And they can do resistance training, they can do whatever they want, but not interval-based and not high intensity. How do we follow up? Do we know if they are doing the exercises? Exercise logs are turned in after 3, 6 and 9 months in both groups. And I have regular contact with the physiotherapists in the local communities before start, because to information about the study at the beginning of the intervention and after 3, 6 and 9 months. And they can call me anytime or send me emails. This is a cooperation study with the local community. So far, we have 68 included patients in Norway, 2 excluded before baseline. We have tested 51 after 1 year and 3 excluded. They are not tested after 1 year follow-up. Further plans, we have published 1 article in American Heart Journal. It's a design article. And we now also have started HIT's 3 years follow-up. We want to see if the potential beneficial effect of 1 year of intensive exercise training sustained for a longer follow-up time. That's really important, and few studies on that. We use the same test battery as HIT's 1 year, but there are no specific intervention. So far, I have tested 13 patients at their 3 years follow-up. A short summary. The results from the HIT study may change the exercise prescriptions recommended de novo heart transplantations as of today. It's too early to conclude. We have no results yet. What we can say something about so far, VO2 peak test before discharge from the hospital and at 1 year follow-up, yes. Close follow-up and cooperation between special healthcare and the local community, yes. And a systematic exercise in the novo heart transplantation patient is the nave in the multidisciplinary rehabilitation wheel. So the road is not always straightforward, as this illustration shows. Be patient, go step by step. Thank you for your attention.